one of the premier hospitals maternity hospitals in Sri Lanka. And our main interests are particularly development care of newborn, recognizing the importance of emotional, psychological, and physical aspects of preterm infant and the families to lessen the long-term and short-term impact associated with specifically the hospital stay. And also she concentrate on great care to minimize the long-term consequences. And with that, I would like to introduce Dr. Lucas, invite Dr. Lucas for her presentation, and she'll come virtually.
Thank you, Madam Chairperson, for that kind introduction. So I think my job has been made easier by the previous two speakers, and I'm going to talk about the long-term consequences of preterm birth. So why do we need to consider the long-term consequences? Why is it important? What are the long-term consequences? How do they occur? What is the role of inflammation? And most importantly, how do we minimize the damage and try to achieve better outcomes? So I think I can go over the first few slides because it's an introduction as to why we are talking about it and why this is important. Preterm births are increasing, and it's about more than 50,000 births per year, of which 10% are very preterm and 5% are extremely preterm. And not only are the amount of births increasing, but survival is also increasing. And more younger babies at younger gestations are surviving. So this is a graph from many countries. This is a graph from, well, not so new, but from the UK, which shows that survival is around maybe less in between the 22 to 25 age group, and it is more in the more than 28 age group. So we know that babies are surviving, more and more babies are surviving, and the age of the gestation of survival is getting less, where even 24-weekers are surviving even here in Sri Lanka, not so much, but there is some intact survival, but survival over 26 is much, much better. So just to again highlight the fact that over time, the amount of preterm babies surviving has increased, and especially in with regard to the younger preterm babies, the extreme preterms between 22 to 25, the amount of preterm babies surviving are increasing. But also importantly, not only are they increasing, but it's important to see, are they having any morbidities? What is the cost of that survival? So this is why it's important to talk about long-term consequences, because being preterm itself has a lot of implications, and that can have an effect on the long-term health of these babies, which can in turn cause issues and can become a burden to the health system. Okay, so preterm survival may come at the expense of future adverse health and social risk, which is characterized by they may fail to achieve the optimal development, or they can have issues with their organ functions, or they can have what is called as accelerated aging. So what are the long-term consequences of preterm birth? So when it says long-term, these are really not the ones at discharge, not like retinopathy of prematurity and anemia of prematurity. These are more so the consequences that tend to last with these babies to childhood and also to adulthood. So as you can see, there's quite a lot, starting with diabetes, cardiovascular, hypertension, kidney disease, asthma, pulmonary function abnormalities, neurocognitive and psychosocial disorders, as well as poor social adaptation. So does preterm birth increase the risk of death at all stages of life? Yes, it does. So that was a Swedish study that was done on around a large number of live births who were born in 73 to 79. The study was done in 2008. And it showed that lower the gestational age at birth, the higher the risk of death, not only in the neonatal period, but also in the postnatal period, early childhood, as well as in the young adult age. So almost half of all preterm births are caused by an inflammatory process. And it is described as the first inflammatory injury or the first hit in utero at the fetomaternal surface, which I think Dr. Landrose spoke about. So it's about what happens at preterm labor, when there is rupture of membranes, when there is chorioamnionitis, the first bout of inflammation that hits the baby. Then after the baby is born, there can be a second inflammatory hit. The baby is very vulnerable as it is, with having again a very immature organ system and immature immune system. So this can make things worse. And how? Because of all the devices we have to use, the drugs, the methods of giving nutrition, the hospital organisms, the hyperoxia, smoking, air pollution, all that will have a role. So some we can avoid, many we can try to avoid, but there would be some that still are there. So the risk profile of preterm infants for sustained inflammation and long-term vulnerability, it's a complicated looking figure, but what it says is there are lots of things actually. So being preterm in itself is an issue. The gestational age, the birth weight, the gender, the genetics play a role. So as neonatologists, we kind of start from there, but from the obstetrician's point of view, there may be some things we can do to prevent prematurity per se. And then there are other things that happen with the environment, with the presence of rupture of membrane, the presence of chorioamnionitis, invasive measures, so on and so forth. And with the risk of sepsis and inflammation, that would decide what the long-term outcome would be. So the degree of inflammation that is the baby is exposed to, and whether it is also exposed to infection, would kind of plays a large role in determining the long-term consequences. Whether how much the lung is going to be involved, what sort of effect it will have on the brain, the cardiovascular system, the kidney, the growth, as well as on the metabolism. So human milk feeding, vaccination, anti-inflammatory therapy, developmental care are protective, whereas being exposed to passive smoke, infection, antibiotic, lack of early support is not going to help the baby and will further increase the risk. So the impact of sustained inflammation on the preterm, as you can see, again, it's a very complicated diagram, which I don't think we need to go into in detail, but what it shows is when a preterm is born, there are effects on almost all the organ systems, from the brain to the lung to the kidney, the heart, the immune system, and also the microbiome in many, many ways. So if we go through one by one, I'm going to start with the lung. So there can be an effect on development of the lung. So that's why we are just looking at the stages of development of the lung. If the baby, because we are focusing more and more, actually, it's more of a challenge to handle a baby who is born less than 26 weeks or less. More than 26 weeks, if the baby comes out in good condition, survival or intact survival, unless there are some problems on the way, it's not, is quite easier than a baby who is born less than 26 weeks, which is much more challenging. So alveolar development has not commenced in babies less than 26 weeks, hence a lot of issues that we face. And as Dr. Gupta mentioned, we find it very hard to put them on CPAP. The apparatus doesn't fit sometimes, it's not big enough to fit them, and they are unstable most of the time, and it requires ventilation. So there is reduced surface tension due to various things, which is actually plays a role in the initial respiratory distress syndrome. But then again, the extrauterine insults on the immature lung will play a role in causing pulmonary hypertension through abnormal alveolarization and vascular development. So preterm birth also causes increased dead space ventilation, lowering of the functional residual capacity, and impaired gas exchange. This is just by being preterm because it has an effect on the lung growth. So if you look at lung growth, there are postnatal factors as well as prenatal factors, which we spoke about genetic factors, fetal-maternal factors, placental, chorioamnionitis, all that. And also whether the mom is having diabetes, obesity, all that will play a role, as well as being preterm per se will cause respiratory distress syndrome, and through that there can be issues with barotrauma, hyperoxia, through which there can be which can lead to pulmonary inflammation. Again, infection can lead to pulmonary inflammation and reflux or fluid overload. So there are many ways that can lead to pulmonary inflammation, which in turn is going to affect lung growth. And if it affects lung growth, it is going to cause long-term consequences. So there are all preterm babies do not have chronic lung disease, but the lesser gestation they are, the more chances that they will have chronic lung disease. So which preterms are at higher risk for getting chronic lung disease? If the mother has pregnancy-induced hypertension, chorioamnionitis, diabetes, if there are issues with nutrition, if the baby is already growth restricted, if the baby has accelerated catch-up growth, if the baby is exposed to smoking, either by the mother or passive smoking by anybody else around the baby, and also social deprivation. So there are many, many factors that actually have an effect on the lung growth and the pulmonary function. Prematurity per se increases the risk of wheeze, the risk of inhaler use, and the risk of the incidence of hospital admission. As you can see, in preschool age group, school age group, and both preschool and school age groups. And the younger the baby, higher the risk. If the preterm has had chronic lung disease, it is associated with poorer respiratory outcomes, with increased risk of wheeze, inhaler use, and nocturnal symptoms. So these symptoms have not been confined to their early childhood to the first year, but at 6 years it has been more. And even at 11 years, there has been higher incidence of asthma in preterm, as well as in babies with chronic lung disease. And they also have increased risk of pulmonary hypertension because of the abnormal vascularization that follows. So now we were talking about how the preterm lung issues are carrying on to childhood, but it is not only on to childhood, it also spills on to adulthood, where cough, wheeze, asthma-like symptoms, because it looks like asthma, but it's not exactly asthma. They think it's different, the pathophysiology of it. So they are often wrongly labeled as asthmatics, and they don't really respond very well to the treatment. And the physicians identify that they rarely take a neonatal history, and that they should, because adults who are born preterm have a different entity which looks like asthma, but it's not really asthma, and it needs to be identified as a different entity. There is partial reversible airway obstruction, respiratory symptoms, and HRCT imaging is also different in adults who were born preterm. And Wong had found that up to 71% of the people had abnormalities between 17 to 33 years. But a word of caution, all the adult data we have about neonates are reflecting the neonatal care that was about 20 years ago or more. So with better care, hopefully things are not so bad, but still there are things that we can improve. So how does prematurity lead to respiratory dysfunction in adulthood? There is airway obstruction at birth, which leads to airway wall thickening and abnormal parenchymal development. There is failure to achieve normal airway growth, where the alveoli number usually increases till 2 years, but with prematurity, it can have an effect on that. And after that, the alveoli increase in size. But again, being born preterm, it can affect both of that. And it has also been shown, as you can see in the graph that is shown alongside, that adults who have been born preterm are showing accelerated decline in lung function with lower exercise capacity. And fetal programming is meant to play a role in this. So moving on to the brain. So we saw that it is not only the chronic lung disease people that have issues, even just being born preterm, even being born at 35 to 36 weeks can still have respiratory issues. So the preterm brain responds differently to injurious exposures via the astrocytes, microglia, and the peripheral immune cell migration. The earlier the exposure, worse the outcome, which can be further worsened by stress and smoking. The extremely preterm infants are even more susceptible. So the moderate and late preterm children have a higher risk of developmental delay, where the language domain is most affected and which has been detected at 2 years of age. Also, behavioral problems had been found at 7 years of age, and there's a higher risk of having intellectual dysfunction. So again, this is just to show there are some studies that have been done on the neurocognitive outcomes, but then again, you can see it's a pretty old study done in 1995, which reflects the neonatal care quite a while back. So there are actually lots of consequences on being born preterm, where the risk of attention deficit disorder, anxiety, cerebral palsy, schizophrenia, and many behavioral disorders are increased. Preterm birth increases motor disorders, and the risk is higher if the baby is, the smaller the baby, the risk is 8 to 10% higher with intraventricular hemorrhage, and it's 25 to 50% higher if there's white matter injury. They also have a higher risk of thromboembolism. Preterm birth also affects behavior. They have, as adults, they have been found to have lower tendency for risk-taking behaviors like smoking and drinking, and they have a higher risk of being victimized, of being bullied, socially excluded, and they are at higher risk of social withdrawal, being introvert, and having neuroticism, which is a risk factor to get depression. And what leads to this? Studies which have looked at what led to this had found out that adverse perinatal events and painful procedures. Hence, we should be very mindful to keep our babies comfortable during any pain-inflicting procedures. Preterm birth also increases psychiatric conditions like anxiety, inattention, autism, psychosis, schizophrenia, mood disorders, eating disorders. But these have been found mainly in children who have had other brain impairments with regard to motor, speech, or learning. It also increases learning disorders with regard to lower IQ, mathematics, reading, earning capacity, and thereby less employment, less self-esteem, and more likely to remain single. So preterm birth also has an effect on sleep, where there is a higher risk of obstructive sleep apnea. Again, having chorioamnionitis at the time of birth has shown to increase the risk of obstructive sleep apnea. And they also have a higher risk of snoring. So there is also something called the gut-brain axis, where there is a complex interplay between the gastrointestinal tract and the nervous system via the neural, endocrine, metabolic, immune factors. And necrotizing enterocolitis has a large role to play. So why does that happen? That happens due to issues with the microbiota, dysbiosis because of the imbalance, increased expression of pro-inflammatory mediators, and increased neurodevelopmental dysfunction and abnormal MRI brain with prolonged exposure. So how do we overcome this problem? How can we make things better for the preterms we are saving? By using breast milk for feeding, less invasive care. So we need to make sure we minimize inflammation as well as infection. So all measures taken to minimize infection become very important. Hand hygiene, judicious antibiotic policies, and shortening the duration of inflammation in necrotizing enterocolitis with using probiotics, and early termination of infection had been advocated by pediatricians and so what does inflammation do to the preterm gut? So major risk factors for inflammation would be the immature mucosal barriers, immune cells, reduced motility, and there is increased risk of dysbiosis and bacterial overgrowth by the short chain fatty acids, biotransformed bile acids, and epigenetics. And there are also other factors, extraneous factors like chronic ischemia during the pregnancy, having chorioamnionitis, antibiotic exposure, as well as parenteral nutrition. I will go into a little bit more detail as to how parenteral nutrition is involved in all this. Um, so there are risk factors for sustained inflammation, and the outcome can be pretty scary with growth failure, short bowel syndrome, and inflammatory bowel disease, which puts these preterm babies at higher risk of all these issues. Again, prevention is using human milk, avoiding formula milk, using pre and probiotics. So preterm birth also increases the risk of adult cardiovascular disease. It leads to increased systemic blood pressure, both systolic and diastolic. Having preeclampsia in the mother further heightens this risk. And the baby having extrauterine growth restriction, this means growth failure after the baby is born, also increases the risk of having higher levels of blood pressure. The blood pressure is inversely proportional to the gestational age. Not only is it blood pressure, but the left ventricular mass also has shown to be increased, which is and show an inverse relationship to the gestational age. And there's also a risk of heart failure. The younger the baby, higher the risk. Preterm birth also affects the kidneys. Nephrogenesis is altered due to prematurity. Exposure to hyperoxia impairs nephrogenesis with 25% for lesser nephrons. Babies who are born preterm, sorry, it's not really babies, the adults who were born preterm had been seen to have smaller kidneys on ultrasound scan, but they have not been shown to have a marked loss of function in all studies, whereas some studies have reported mild dysfunction. However, the problem is that they are at higher risk of acute kidney injury. And if they do get acute kidney injury, they get hyperfiltering glomeruli and become at very much more higher risk of getting chronic kidney disease. Again, if the kidneys are affected, there is another risk of getting higher blood pressure. How do we prevent it? By avoiding hyperoxia, optimizing nutrition, and avoiding nephrotoxic drugs. So we saw that the effect of preterm birth on the lungs, the brain, the gut, the kidneys, it also has an effect on metabolism, possibly due to pancreatic beta cell dysfunction, because these are mainly formed in the third trimester. So it leads to higher fasting insulin levels, higher need of insulin and oral hypoglycemic agents, higher incidence of diabetes. And again, a risk factor has been found to be the presence of rapid catch-up growth, which would lead to increased visceral adiposity. Preterm birth also affects the lipid metabolism, where adults who are born preterm are found to have higher levels of LDL, higher levels of cholesterol, and abdominal fat has been found to be higher in preterms with growth restriction. So having restricted growth worsens things, and accelerated weight gain with regard to length after the term age further worsens things, because that growth mainly involves increasing in fat with higher weight circumference, higher triglycerides, and higher risk of non-alcoholic fatty liver disease. So this is again another paper which had gone into lots of detail, and some meta-analysis which shows high levels of blood pressure, high levels of lipid, fat mass, and cholesterol in adults who are born preterm. So why do these things happen, and how can we try and prevent this? So possible contributors to this chronic disease. One, thing is the inflammation and the pro-oxidant intrauterine disturbance, which is meant to happen with maternal conditions like chorioamnionitis, preeclampsia, obesity, diabetes, infection, prolonged rupture of membranes, which all lead to increased inflammatory cytokines and reduced antioxidant enzymes, causing harm to the baby. And also massive increase in oxygen. So this can happen after birth when the baby leaves the intrauterine environment and enters a much more oxygenated extrauterine environment. And also on top of that, the baby will need ventilation, so baby will face a massive surge of oxygen. And there are other things that might increase pro-oxidant molecules like parenteral nutrition, antibiotics. Formula milk also increases pro-oxidant molecules, hence breast milk is preferred. And also that disruption of dark light cycle, circadian rhythm, sleep pattern can all cause issues for this baby. So again, there is a thing called the hypoxia inducible factor. So it drives organogenesis and vasculogenesis. So when the baby is preterm baby is exposed to ex utero oxygen-rich environment, this hypoxia inducible factor decreases. And it is through that it is thought that impairs the nephrogenesis and impairs the myocardial metabolism. So again, epigenetics also plays a role where the antenatal and perinatal exposures to chorioamnionitis, preeclampsia, glucocorticoids, maternal diabetes, and maternal depression leads to epigenetic changes, which may lead to behavioral alterations. It has been found in human cord blood and also in animal organs and it has also been found that DNA methylation in preterms had not resolved by 18 years. So I said I will tell you a little bit more about why is parenteral nutrition, which we think is a cornerstone of giving nutrition to these preterm babies, why have we listed it out as a risk factor for long-term disease? So there is an in-the-bag reaction which can occur where peroxides are formed. Inorganic as well as organic peroxides are formed, and this reaction is catalyzed by the photosensitive riboflavin. So this actually will cause issues and put the baby at high oxidative stress. It should be detoxified by a different set of enzymes, for which glutathione is also a very important thing. But glutathione is directly related to the gestational age and the sex. So if the younger the baby, the more preterm the baby, the less glutathione they will have, and male babies also has less glutathione, so they will face more problems. It has been shown that young adults exposed to intravenous lipids had showed increased aortic rigidity and decreased left ventricular function. DNA methylation has also been there for 2 months, even after the parenteral nutrition has been stopped. So how do we prevent it? We can cover the whole apparatus that we use to give the parenteral nutrition. That is by photoprotection, which would in turn has been seen to lower the triglyceride levels, the blood glucose levels. It has improved the nutrition, stabilized blood pressures, and reduced the amount of bronchopulmonary dysplasia, as well as reduced mortality. So in a way, in Sri Lanka, our parenteral nutrition still comes in the form of amino acids and lipids, which we give separately, and we don't have vitamins in it. So maybe this is kind of a little blessing in disguise, where we are not exposed to this, but of course peroxides can still form, but the catalyst is not there in the solution that we give. So moving on to prevention. So how we talked about a lot of things that can go wrong and what can go wrong and how it can happen. So we can optimize the parenteral nutrition to decrease the peroxide load. There's amount of vitamin that needs to go in there, and if we exceed that, the peroxide load gets high. We can also cover it to reduce the catalyst working, optimize neonatal nutrition, make sure breast milk is given to babies and not formula milk. Then optimizing the growth. We have to make sure that we don't try to push babies up to the green line or wherever, but the baby should go on the growth curve where the baby is born, because getting excessive rapid catch-up growth, especially after term age, is going to put them at higher risk of visceral adiposity and lipid metabolism and glucose metabolism, as well as liver injury. Avoiding second hits as obesity, acute kidney injury, ensuring long-term follow-up, and involving the families of these preterm babies. So I'm just going to show you this again. I know you saw this earlier, but this is how we have to work on reducing the amount of lung injury that our babies are exposed to. So prevention from infection, make sure you are very vigilant about the amount of oxygen that is being given, prevent hyperoxia, it has many issues. Barotrauma, PDS can be treated soon, avoid it, avoid fluid overload, avoid reflux, and prevent intraventricular hemorrhage by avoiding blood sugar fluctuations, keeping baby calm, and preventing periventricular leukomalacia by avoiding hypocarbia, avoiding hypoxemia, and provide developmental care. Be attentive that there should be pain relief with procedures that cause pain. Make sure there are two people for a procedure, that someone is holding the baby, talking, grasping a finger. Optimize neurodevelopment, optimize nutrition by promoting and establishing breastfeeding, prevent infection, minimal handling, less invasive care, shorten the duration of necrotizing enterocolitis, developmental care, neurological evaluation, as well as early stimulation. So minimize interventions, more problems. Make sure we don't do any punctures to take blood, but it's by heel prick. You said day and night, getting the baby exposed to the day and night cycle is important. So therefore, ensure that developmental care is practiced. Use incubator covers, nests, be aware of the baby's behavior. Prevent gut and kidney injury by using pre-probiotics, breast milk only, no formula milk, avoid nephrotoxic drugs, optimize infection. So although it sounds pretty, it paints a very dark picture, we do have many babies with us because most of our survivors are 26 weeks and more. So this is just thought I'll share some pictures with you who are neurologically intact, but they are still young. We need to see more. So this is a 625 grammer who was with us. And this is a 525 gram baby born at 26 weeks, I think. Thank you for your patient listening.
Thank you, Rishani, for your comprehensive lecture on long-term consequences of preterm. So I think we are running out of time. So before we close the session, on behalf of the Perinatal Society of Sri Lanka, let me thank all three speakers, Dr. Sanat Landral, Dr. Amit Gupta, and Dr. Nishani Lucas for their wonderful, wonderful presentations. I think that's all from here. Thank you very much.
Next, I would like to invite Dr. Kapilani Jayasekara to present a certificate of appreciation to our chairpersons. Time has come for the last session of Day 1 of the Annual Scientific Congress of Perinatal Society of Sri Lanka. I would like to warmly welcome on stage Dr. Padmaka Silva, Consultant Community Physician of Family Health Bureau, to chair the event.
Good afternoon to all of you. Let's move on to the last session. Our next speaker will be Professor Asanna Ahmad Kamar, who is a consultant neonatologist and associate professor in pediatrics and neonatology. Let me introduce Professor Asanna. He is an associate professor and consultant neonatologist at the Faculty of Medicine, University of Malaya, Kuala Lumpur, Malaysia. She was also a team member of the Irish National Neonatal Transport Program, and at present heads the Neonatal Intensive Care Unit of the University of Malaya Medical Center. Her interests are in pediatric bioethics, Cochrane systematic reviews, ventilation, infant nutrition, infection control, quality improvement initiatives, neonatal transport, and neonatal innovations. And also she is a past president of the Perinatal Society of Malaysia and is a member of the writing team of the Southeast Asia Early Nutrition Academy and e-learning infant nutrition platform under the EU Erasmus e-learning collaboration. So his topic would be neonatal sepsis, management conundrums and outbreak containment. Over to you, Professor Asanna Ahmed Kamar.
Thank you very much. First of all, I would like to thank the organizers for inviting me to the prestigious Congress in Sri Lanka. This is most certainly awkward. I mean, I thought I could be there, but all of us are across the world elsewhere. And I was fortunate enough just now earlier on to listen to Dr. Amit Gupta as well, and some of the speakers before this. And so I hope we can learn each other from this Congress, and I will be speaking on a topic that is rather intriguing, perhaps somewhat frustrating for many of us. Okay, so basically I'll be speaking on neonatal sepsis, the management conundrums, and outbreak containment. And we know that the diagnosis and management of neonatal sepsis is fraught with a lot of challenges. The hardest is that it's very difficult to diagnose. We can never agree on a proper definition. And once we do diagnose, sometimes we'll be getting things like culture negative sepsis, and therefore it is extremely rather difficult to undiagnose. And once we've started antibiotics, we are increasingly seeing more and more antibiotic resistance. And therefore, the organism itself may be very difficult to kill as we see higher and higher resistance rates. And once that organism is let loose, then it can be extremely difficult to handle. It spreads very easily. And more often than not, we feel that this is a very large battle. It really feels like we are that incy-wincy spider climbing up the pipe, only to be washed down by the rain. And it's really something that's fraught with a lot of challenges. And what we also wish for is that we will not have to deal with all these headlines, because as the consequences have huge impact to the society in general, and much more closer to home in Singapore, in Kandang Kerbau intensive care, and then in Cardiff, 12 babies with infection closed at Cardiff. So with all these in the background, so the aim of this half an hour lecture, I will try to go through quickly and enable all of us to have a three-pronged aim in trying to understand the impact of neonatal sepsis and the dilemmas of its definition. And as a consequence, we could ensure targeted management of sepsis despite all these conundrums. And at the same time, understand methods and the need to contain any neonatal ICU outbreak in a timely manner, which is of extreme importance. And we'll move on to the challenges. First of all, we know that neonatal mortality, whenever we aim for any ultimate outcome, is actually to aim for a reduction in neonatal mortality. And reduction in neonatal mortality from between 1990 to 2015 has lagged behind post-neonatal under 5 years mortality globally. And therefore, when it comes to providing the SDGs, and especially from the WHO Every Newborn Action Plan, is that by 2035, all countries should have at least 10 or fewer neonatal deaths per 1,000 live births, or 12 or fewer neonatal deaths by 2030. And what more better way to do this by reducing neonatal infection, as neonatal sepsis has been shown to be the top one of the top causes of neonatal mortality overall. And we know that up to almost 40% of global under 5 mortality is due to a consequence of uh, conditions that's related to preterm births and consequently conditions related to neonatal sepsis. And in South Asia, we know that it's even higher, 2 to 4 times higher in countries like India or Sri Lanka and Bangladesh, and that from that reported in Western countries. And the range can be up to even 50% and up to 80% mortality rates as reported by Bolat in Turkey for late onset neonatal infections. And we know that it's extremely expensive, up to 129,000 USD for hospitalization due to sepsis has been reported. And this is actually due to the longer length of stay, higher morbidities among survivors, and therefore the cost is enormous. And we understand the risk factors for neonatal infections, and this include low gestational age and use of central catheter, as well as use of invasive ventilation. And in my country, in Malaysia, this is from our Malaysian neonatal registry, whereby up to where we audited more than 16,000 babies of less than 32 weeks in 44 Malaysian hospitals. We note, for example, that there is at least about 38.1% late onset sepsis rates in extreme preterm babies delivered at the cusp of viability between 22 to 24 weeks. But we did pretty well in terms of those of higher age group, those at higher gestational age, up to 5% late onset sepsis rates in these babies. But one of the major cause of mortality and sepsis associated morbidity is actually necrotizing enterocolitis, where we saw 4.4% inborn babies of gestational age, less than 2 weeks, developing necrotizing enterocolitis with up to 20, almost 21% requiring surgery. And the incidence of necrotizing enterocolitis is actually independent of age. And independently, in many reports and many studies, we know that sepsis is, the rate of sepsis actually increases with use of supportive devices, and especially factors related to hyperalimentation or parenteral nutrition, whereby the risk factor and adjusted risk actually increases in view of these kind of use of supportive devices. Okay, and the other risk factors include mechanical ventilation, central line, peripherally inserted central catheter, and as well as antibiotics such as vancomycin. And the use of H2 blockers and proton pump inhibitor use also increases sepsis risk. And what is disturbing is that because of use of antibiotics, which we need, we are seeing an increasing number of antimicrobial resistance, and the proportion of drug-resistant organism causing infection in the NICU, including bloodstream infections, is increasing. And from a Medline search for words such as MRSA, VRE, or vancomycin resistant Enterobacter, extended spectrum beta-lactamase, ESBL, and CREs, carbapenem reducing organisms, show a very sharp increase in the number of NICU specific publications regarding these resistant organisms. And a review of worldwide database of healthcare associated infection has found ESBL producing gram-negative organisms and MRSA listed as the causative pathogens of more than 15% of NICU outbreaks. And these have actually led to something that we really fear, unit closure during the outbreak period. And what we fear more is that if our use of antibiotics can alter a lot of things and actually can cause outbreaks within the community itself. And that is an even worse fear that we can face. Now, the increasing antibiotic use as a result of these neonatal infections has led to multiple reports which now suggest harm from early and prolonged empirical antibiotics, including a higher risk of late onset sepsis reported in babies who had early prolonged use of antibiotics. And there is an increased odds of primary composite outcomes, especially mortality, and as well as stage 3 or higher retinopathy of prematurity, as well as bronchopulmonary dysplasia and other pulmonary outcomes with infants who actually received prolonged early antibiotics. And this is actually significantly has been attributed to the fact that prolonged use of antibiotics cause significant disruption of early life microbiome, and which is essential for the development of neonatal immune response. And therefore, I move on to, after we've understood impact, the conundrums and why, how and why is it so difficult and why is this happening? The main cause or the root cause is basically there is a lack of consensus. We really need a definition of neonatal sepsis. Now, Singer has actually defined sepsis as life-threatening organ dysfunction caused by a dysregulated host response to infection. And when we wanted to test this definition, now this from this study performed by the Better Outcomes Through Research for Newborn Network Survey, or the BORN Network, which represented about 97 nurseries in 34 states across the United States. And they mainly asked primary or general pediatricians that provided the basic care for these neonates, and to determine the extent of clinical practice variation. And in this study, more than 80% actually would look at the perinatal risk factor of chorioamnionitis in isolation as the trigger to at least perform blood investigations for infants, of mothers who had chorioamnionitis. So you can see this large number here, and this is probably triggered by the previous AAP guidelines, which looked at mothers with chorioamnionitis as a trigger to conduct laboratory tests and to start empirical antibiotics. So the root cause when it comes to the conundrum of when do we start antibiotics, is the root cause is basically because there is an inconsistent definition of sepsis, as well as inconsistent definition of maternal chorio. Because maternal chorio itself is very difficult to diagnose. In fact, it actually requires a pathologic diagnosis where you can find inflammation of chorionic and amniotic layers of the fetal membranes confirmed by the pathologic review of the placenta. Although the diagnosis that we are more used to would be maternal fever with at least 2 of uterine tenderness, fetal and maternal tachycardia, maternal leukocytosis, and foul smelling amniotic fluid. So in view of this dilemma of early onset sepsis definition, we know that actually, even though there are mothers with quite a number of mothers with chorioamnionitis, and what the obstetricians have been saying, that we are only diagnosing the tip of the iceberg of chorioamnitis because the rest are actually subclinical. And therefore, for the fear of finding out that subclinical chorioamnitis, we start empiric antibiotics. Although, if you were to look at the overall incidence of early onset sepsis, it is fairly low at 1 in every 2,000 live births. And the risk-benefit ratio, or the risk-benefit balance of empirical antibiotic treatment in this low incidence population is therefore rather of a concern. But I'd like to just point to a descriptive study done by Ian, and where they looked at asymptomatic infants who are of more than 35 weeks of 45 weeks gestation, delivered to mothers who had chorioamnitis. And amongst these, 32.5% actually had some degree of symptoms or an abnormal blood parameters, because their usual way or method is by actually at least observing these babies. And they only found, out of these 32.5% who are admitted, only 15% were culture positive with a median stay of 7 days. So therefore, it brings down to the dilemma: are we okay with clinical science alone, or routine blood investigations? Should these be mandated? Now, because neonatal clinical science may be actually due to physiologic transition, therefore the babies that were admitted, like the one that was described by Ian, could have been because of the physiologic transition, and therefore they were admitted. And there is a high risk of missing these signs with untrained staff and limited resources. And therefore, several studies actually have looked into the use of sepsis risk calculators for early onset sepsis. And these sepsis risk factor calculators, such as this one that I'm showing right now by Kaiser Permanente, which calculates the probability of neonatal early onset sepsis based on the maternal risk factors and the infant's clinical presentation. And upon this adoption, and as described by Goel in the United Kingdom, it has been demonstrated to reduce antibiotic exposure or use in 3 out of 4 term to near-term infants, and definitely promote earlier discharge with significant impact for healthcare resources. So based on what I have mentioned earlier, so I've summed up some of the recommendations that I feel, despite these conundrums, we need to have a targeted management. And therefore, we would recommend perhaps to at least screen these infants exposed to chorioamnitis with complete blood count. Blood culture, keep in view depending on perhaps other surrogate parameters. But with the exception of preterm mothers, preterm babies, whereby we may think about cultures and starting antibiotics if supportive signs or parameters exist. As recommended by Ian, the safety of approach, whereby we should be conducting supportive laboratory evaluation alongside clinical observation in infants without immediate antibiotic administration for asymptomatic infants, needs further evaluation. Now, how about late onset sepsis? Now, when it comes to late onset sepsis, now it's interesting how Joseph Canty in an article mentioned that there is real diagnostic efficiency of neonatal sepsis, early as well as late, because it's as akin to the old epic of Spartacus, where the Romans knew that Spartacus is dangerous and must be eliminated. So the Romans said, okay, so we must execute everyone. But as what Canty mentioned, identifying a septic needle from a haystack of uninfected neonates is difficult. It's um, it's based on of our gut feeling, perhaps, and therefore we have that conundrum of the words admission, which is not even in the ICD code, to rule out sepsis. And what do we do? When in doubt, we treat. And the diagnosis of culture negative sepsis is again something that we still do not know what to do till date. And I'm afraid that I can't give you a better picture for culture negative sepsis. So because the reason is because we need a very cost effective marker or a test of near perfect sensitivity with a high specificity. And particular table summarized it very nicely, and it was this adapted from Gandhi. And what, in comparison to what we're used to, cultures taking a look at hematological parameters and looking at the acute phase reactants, and more new sepsis markers have emerged. But however, these are expensive. I can just tell you how much I would say procalcitonin alone in Malaysia costs more than 100 ringgit, which is actually more than 25 USD, which is a lot for us. Okay, I mean, it may not be high for those who are in the Western countries, but it costs a lot. And when it comes to sepsis risk scores, these are mainly for early onset sepsis. When it comes to late onset sepsis risk score, these are mainly for monitoring and organ dysfunction progression. And therefore, we are still unsure as to what is best. Now, of these surrogate old and new sepsis marker, I would still count on CRP and procalcitonin. CRP, for example, has a negative predictive value of close to 99%. And I would use CRP as a marker for discontinuing antibiotics if, for example, especially if I have a serial CRP. And in a systematic review, procalcitonin, for example, has shown sufficient sensitivity and specificity up to more than 80%. 82% sensitivity and 86% specificity, well, that we can safely rule in or rule out neonatal sepsis. And okay, so but of course we are, all these are emerging, the genomes, metabolomics, proteomics in particular. And okay, we look forward to all these, including what I have seen lately is artificial intelligence scoring. Now we look at something that's described by Wynn and Polin, as well as Ian Janota actually in his early studies actually described the neonatal SOFA, or the neonatal sequential organ failure assessment. So this is actually based on what really is sepsis, and what really is sepsis is the organ dysfunction. And based on this, it has shown predicted mortality, and a rise in NSOFA score of more than 2 points has an area under the curve of 0.93 by 12 hours on an assessment. And upon integration in the electronic health records, it is said that it can predict sepsis severity and progress. And therefore, in terms of management recommendations, I would highly recommend the use of NSOFA to monitor progress and to have an extremely heightened clinical suspicion, as well as an agreement with your staff and all the other healthcare providers to clearly say, okay, look, this is how we're going to diagnose sepsis, and this is the reason why I said that this baby has sepsis. And this should be individualized according to the baby. So we may move on. So if, let's say, we were to have an outbreak, God forbid, and so we will need to look at this and say, okay, I need to stop it. Now, this is actually, I'm just going to tell you from our experience. Not too long ago, we had something that everybody fears. We had 9 patients in our small NICU of 27 beds. I'd say smaller, medium-sized NICU. That we had carbapenem-resistant Cyanidobacter, whereby actually the majority were from, I say tracheal aspirates, but this is a very scary looking antimicrobial susceptibility profile, I must say. I'm sure you look at this and you're horrified. And within a span of 2 weeks, 3 babies died. And so what did we do? So one of the things that we did was that we tried to stop the outbreak. And one of the ways to do this is by performing or conducting what we call a systematic epidemiological investigation and a systematic method to target interventions. And using a PDSA cycle, we collected the data quickly, mapped out where these babies were, and looked at the movements of the babies, and conducted an epidemiological investigation by the means of doing a microbiology analysis to look at the strains of these babies using PGFE, and we reassessed concurrently the existing infection control practices and performed a root cause analysis. And from our root cause analysis, this is what we found. We had, out of 26 environmental surfaces that were swabbed, we had 1 mini syringe driver. We use a mini syringe driver that is in close location to the baby, and these are actually shared. And there were sinks in the milk preparation room, which actually were contaminated. And from the express breast milk, we found that 3 were contaminated. And we looked back at our refrigerators, we evacuated our refrigerators and all that. And out of the 10 healthcare worker fingerprints, we found 1 that actually was contaminated, but this healthcare worker, we just wanted to prove as to how it moved. This healthcare worker was actually handling the baby, and before she hand washed, we looked at it. And we looked at all the 7 contacts, meaning the parents, and we found none. And we conducted a PFGA analysis and found that these were related to one another. And based on these analysis, we conducted baseline and targeted interventions, as well as conducted subsequent education, and we revisited our guidelines quickly, okay? And when we, one of the things that we did was actually we heightened surface cleaning, and the education included our cleaners. We found that there was suboptimal dilution of the cleansing solution. And we also re-looked at our milk handling protocol due to the express breast milk that became contaminated. And we made sure that these breast milks were tidied and all actually had individual slots within the refrigerator itself. Okay, but the most important thing that we learned from this outbreak is that when you want to manage an outbreak, you have to stop it before it happens. And therefore, what we actually conducted is that we used something, we knew about good infection control practice. We performed prospective audits with timely feedbacks, and straight away, subsequent to that, we said that we need to have antibiotics stewardship. What is most important is a multidisciplinary approach to it, because we understand that the NICU actually has a very complex adaptive system. And because of that, there is human fallibility and possible medical errors. And therefore, we launched our comprehensive unit-based safety program, which looked at late onset healthcare associated infections in neonatal ICU as a critical incident. So we were not happy with two. I mean, we said that as soon as we have one bloodstream infection, you need to conduct a root cause analysis. One incident or one healthcare associated infection is a critical incident. It is akin to a medical error. And what we wanted is that we wanted to avoid this. And based on the CAS model, we assembled the team, we engaged the top people, the senior executive, including our quality control, as well as the infection control, as well as the director of the hospital. And we identified defects through sense making and learning all about the science of safety. And the teamwork and communication was reinforced. And this was actually conducted through a collaboration with Johns Hopkins Hospital. So we learned everything about CUSP, and therefore we launched our CUSP in collaboration called the Sparkling Clean, or the PIN is called Prevention of Infection in Neonates. And we looked at all these parameters together with the team. And this also involved our pharmacy team, as well as the team from quality department. And the subsequent to that is the final bit about staff education, empowering parents to tell us to stop if, let's say, we don't wash our hands. And we launched our campaign and all the education. And this is just an example of our bloodstream infection root cause analysis review. We looked at every single tool or equipment that that particular baby has. And subsequent to that, we launched our antibiotic stewardship program, which actually comprised of ensuring that we make the diagnosis accurately and that we should be agreeing with one another about the diagnosis together with the infection control. Okay, and we relaunched our antibiotic stewardship program recently alongside our medication safety program. So basically, safety as well as infection control comes hand in hand together to curb or nip any outbreak at its bud. And therefore, learning from this, infection control and prevention of infection doesn't come from a single person. It needs a concerted effort, defined goals, and definite rewards are required, and never forget to celebrate success. I'd like to thank our CUSPIN project collaborators, including the team from Johns Hopkins, as well as the Dean of the Medical Faculty and our Infection Control Department. And lastly, I would like to end the slide. As most of us cannot travel now, here is a glimpse of Malaysia. And this is KL Tower when we celebrated our World Prematurity Day on the 17th of November. And unfortunately, our baby, we had a very good baby who passed away on World Prematurity Day just this year due to sepsis, and we were extremely sad. Anyway, do come to Malaysia once we are out of this. We are a diverse, multi-ethnic, multicultural society. Basically, anything that we need to do, we need to consider all aspects and intricacies. Thank you very much to Sri Lanka. Bohoma Istuti. I hope I got it right. Thank you very much.
Thank you, Professor Asana, for enlightening us with that wonderful presentation. And I think we are already running out of time, and that brings us to the end of plenary sessions today.
Thank you, sir. It's now my pleasure to invite Dr. Kapilani Jaisekara to present a token of appreciation to our chairperson, Dr. Padmaka Silva. Also, madam, we would like you to join Dr. Padmaka Silva in awarding certificates of participation for the poster presentation held earlier today. And the participants are Dr. P.G.W.S. Samaranayaka, Dr. K.M. Parakrama, Dr. D.G.T. Rukshani, Dr. J.P. Silva, and Dr. P.G.C.G. Kaushalya. Thank you, sir. Ladies and gentlemen, that concludes today's proceedings. Thank you very much for your enthusiasm and your presence here today. And all of you who joined with us virtually from all over the country, thank you for your support and dedication. We hope to see you all tomorrow for Day 2 of the Annual Scientific Congress of Perinatal Society of Sri Lanka for yet another enlightening experience. Refreshments will be provided outside. Have a great evening. Thank you.